Bismillah ar-Rahman ar-Rahim. Idiopathic pulmonary haemosidrosis, a rare disease of undetermined etiology characterized by recurrent episodes of alveolar hemorrhage and hemoptysis in the absence of renal disease, usually leading to iron deficiency anemia. The pathophysiology of idiopathic pulmonary hemosiderosis: the alveolar space and interstitium contain hemosiderin-laden macrophages with variable degrees of interstitial fibrosis and the degeneration of alveolar, interstitial, and vascular elastic fibers, depending on the chronicity of the condition. Electron microscopy shows damage to the endothelial and the basement membrane, but no consistent or diagnostic features have been recognized. No antibodies have been identified, though serum IgA levels are sometimes raised. With recurrent alveolar hemorrhage, the alveolar blood provokes a fibrotic reaction with the development of diffuse pulmonary fibrosis. Iron turnover studies show that accompanying iron deficiency anemias is due to loss of iron into the lung through hemorrhage. Etiology: uncertain, but likely to be multifactorial. Possible associations include toxic insecticides, epidemiological studies in rural Greece, premature birth, and fungal toxin exposure. The disease has an equal sex incidence in childhood, with twice as many men affected in adulthood. Most patients present in childhood, with 85% of cases having onset of symptoms before 16 years. The actual prevalence is unknown, but a cohort study of Swedish children in the 1960s described an incidence of 0.24 per million children. Familiar clustering is reported. Pulmonary hemosiderosis is associated with rheumatoid arthritis, thyrotoxicosis, celiac disease, and autoimmune hemolytic anemia, suggesting a potential autoimmune mechanism. The clinical features of idiopathic pulmonary hemosiderosis: the clinical course is very variable and ranges from continuous low-level bleeding to massive pulmonary hemorrhage. The latter may be fatal, but is fortunately rare. Continuous mild pulmonary hemorrhage leads to a chronic non-productive cough with hemoptysis, malaise, lethargy, and failure to thrive in children. Iron deficiency anemia is common, as a positive as are positive fecal occult blood tests due to swallowed blood. Generalized lymphadenopathy and hepatosplenomegaly are recognized, with an acute bleed, cough, and hemoptysis may worsen, and dyspnea and chest tightness and pyrexia may develop. Chronic bleeding lead to chronic disabling dyspnea, chronic anemia, and the clubbing in 24% and 25%. Core pulmonale secondary to pulmonary fibrosis and hypoxemia may develop. Examination may be normal. Clubbing, basal crepitations, and the core pulmonale are all recognized, depending on the severity of the resulting lung disease. Investigations: the diagnosis is one of exclusion with no evidence of other organ involvement. The main differential diagnosis is Goodpasture syndrome, granulomatosis with polyangiitis, Wagner's, systemic lupus erythematosus, and microscopic polyarthritis. Blood tests: microscopic hypochromic anemia with low iron level, antinuclear cytoplasmic antibody, double-stranded DNA, and antiglomerular basement membrane antibodies should be negative. Chest X-ray may show transient patchy infiltrates which worsen during an acute bleed. The apices are usually spared. Progressive disease leads to development of reticulonodular infiltrates and a ground glass appearance that is typically perihilar or in the lower zones. Hilar lymphadenopathy may be seen. Pulmonary function tests. Lung transfusion for carbon monoxide is transiently elevated during bleeding episodes. More than or equal to 130% is abnormal, but this is only usual but this is only useful acutely. A restrictive defect with reduced lung transfusion for carbon monoxide (KCO) may develop with chronic disease. HRCT suggests the changes seen are fairly nonspecific, showing a diffuse bilateral infiltrates with patchy ground glass change. Bronchoalveolar lavage, if done, contains hemosiderin-laden macrophages. Management. There is no specific treatment for idiopathic pulmonary haemosidrosis, and steroids and immunosuppressive drugs such as cyclophosphamide may be of benefit during acute bleeding episodes but don't appear to affect the long-term outcome. There are no published data to guide the optimal timing of treatment during the course of the disease, and the iron deficiency anemia responds to replacement therapy, and the blood transfusion may be needed in severe bleeds. Lung transplant has been tried. Other investigations include routine clinic appointments, and when we do check spirometry and measure hemoglobin and serum iron levels, and ask about increase in shortness of breath or hemoptysis. The prognosis of idiopathic pulmonary haemosidrosis. The prognosis is very variable, with some patients showing spontaneous remission and the other progressing to death. The duration of the disease in the literature ranges from death within days following an acute severe illness to survival with cor pulmonale associated with chronic disease after 20 years.